Welcome to Modern Management of the Older Adult, brought to you by the Institute of Clinical Excellence.
Hello, welcome to the MMOA podcast. My name is Kay Meyer-Domo. I'm an outpatient physical therapist and also a TA with the Modern Management of the Older Adult division of ICE Physio. So today our topic is, but it's not skilled care, or is it? So before we get right into that topic, I just want to point out some of our MMOA live courses and level 1 and level 2 courses coming up. So January 13th to 14th, our first one of next year of 2024, we will be in Marysville, Ohio and Santa Rosa, California. January 20th to 21st, we'll be in Greensville, South Carolina, and Clearwater, Florida. And January 27th and 28th, we'll be in Kearney, Missouri. Level 1, which was previously known as Essential Foundations, will be starting online January 10th. And then Level 2, previously known as Advanced Concepts, will start online January 11th. So today we will be talking about whether return to sport for the master's athlete is skilled care and reflecting on our practices to gauge whether or what we define as skilled care. After the master's athlete master's athlete week of MMOA level 2 online, someone had asked how others promote continued return to sport for our patients with Medicare, especially with rebuttals from maybe non-fitness forward clinicians about how Medicare doesn't cover therapy for sport or athletic activity. So in that discussion, Christina, one of our other lead faculty, noted that the scope of practice for PTs and it was quoted as PT or physical therapy services are those services provided within the scope of practice of physical therapists and necessary for the diagnosis and treatment of impairments, functional limitations, disabilities, or changes in physical function and health status. So just like with our non-Medicare athletes, let's say that a younger patient is a skier and they haven't been able to ski because of knee pain. You better believe that we're trying to get them back to skiing because that's the activity that they enjoy and that's the activity that could decrease their comorbidities in the future and just something that they love to do, and that's their goal. Now, let me ask you this. What if we had an older adult patient that used to ski and wanted to ski again? Are we just getting them to the point where they're walking with no pain, no knee pain? Nope, absolutely not. That is not where we start. So today we're going to be talking about 3 things. First, we'll talk about how the APTA defines medical necessity. Then we're going to talk about what that looks like how we envision that or through our plan of care. And last, we'll talk about why it is important for us to get our patients to this level of function. So the APTA defines medical necessity as determined, it says, as determined by the licensed physical therapist based on the results of a physical therapy evaluation and when provided for the purpose of preventing, minimizing, or eliminating impairments, activity limitations, or participation restrictions. So if we break this down after our evaluation, we have to decide our plan of care and how we can help this patient with the impairments they have, with any activity limitations, or their ability to participate in things related to their lives or that they like to enjoy. So the second part of this statement says, furthermore, therapy treatment is considered medically necessary if the type, amount, and duration of services outlined in the plan of care increase the likelihood of meeting one or more of these stated goals: to improve function, to minimize loss of function, or to decrease risk of injury and disease. As an outpatient orthopedic physical therapist, I see older adults, I see younger patients, I see middle-aged folks, And it makes it really easy to see how people's lifestyle choices can affect them over the years and see how the medical system might have tossed them around or has affected them as well. It's definitely like taking a lifespan approach to treatment, especially when you get the experience of seeing what patients are going through when they're younger and when they're older and when they're in the middle of their years. So there's so much good we can do as physical therapists to get patients on the right track to minimize the things that I mentioned. So we as healthcare providers have the power to make that change with our patients to do exactly what the second part of this statement says, to improve function, minimize loss of function, or decrease risk of injury and disease. And if we think of that in terms of our masters athlete, they're not just trying to get back to walking down the street. They're trying to get to higher levels of activity. And if we just stopped at the point, sorry, that's my dog squeaking a toy. If we only get them back to a level of function that isn't what their ideal is, and they go back to that higher level activity anyway, they could just end up back in PT because we didn't do a good job of recognizing that wasn't where they wanted to be. That wasn't the end goal. It wasn't just get rid of pain and bye, you're done with us. So what can that look like throughout our plan of care? So I think the beauty of physical therapy, and sometimes also the struggle, we can recognize that for sure, is that we take what we know about the patient, their medical history, their past injuries, their current injuries, their current fitness status, their goal fitness status, and make sure we're considering all of those pieces, all of those things, while getting patients back to what they need to do. With the idea in mind that we are trying to get to the root cause of why this is always happening to them in the first place. So let's think of that in an example of a patient. Let's say we have Bob. He's a 70-year-old masters athlete who has right knee pain, really, really loves to participate in CrossFit, and wants to get better and maybe even compete in some level at some point. He isn't quite sure about that part yet, but that's what he wants to do. So he complains of deep squatting that really bothers his right knee. Let's say it's been 3 months since his pain has began, and he stopped going to CrossFit because that's what his doctor advised. He's like, well, if CrossFit is bothering your knee, take a break, rest, don't go. And let's say it starts out with a lot of swelling, and he finally decides like, hey, I think I really need help with this. So his doctor sends him to physical therapy, and on evaluation, what it looks like is that he has a lot of swelling, which has limited his right knee flexion. So if we think about the first part of our plan of care, the very early stages, it may be utilizing some manual therapy to get his full knee flexion back and squatting in ranges of motion that don't bother him, and maybe even using like upper body assist to get into a pain-free deep squat. And we can't forget about maybe doing some cardio to increase blood flow to encourage healing. So let's say he gets to the point where he can squat deeply again. We can start loading it up and making sure we don't ignore posterior chain, not ignoring the hamstrings, we're not ignoring the glutes for sure. And since you are a fitness-forward physical therapist, your treatment sessions start to look more and more like a CrossFit class. You know what? That's okay. That's fine. Because if we're trying to get this patient back to his usual activities, and that includes really higher level activities, not just walking down the street, then it's okay that our treatments look exactly what his goal is. If you think about treating a younger athlete, we're working on cutting with them and being able to run and stop and deceleration drills if they're getting back to a sport that requires all of those things. Right? Right. So we really need to push the limits here and see what they can tolerate and give them ample amounts of education on what to do in case of flare-ups and how to modify on a day where it seems to have gone backwards. So in hopes that they don't just stop going, that they learn how to modify and handle it accordingly. So all of the things we just talked about regarding Bob is in our wheelhouse. Like, we're trying to generate a plan of care for them to get them back to a high level of activity. And that doesn't just stop with mini squats. It doesn't just stop with manual therapy and squatting deeply without any load. If his goal is to be able to squat with, like, let's say 200 pounds, 250 pounds, something like that. So just making those decisions as a physical therapist is what makes our treatment sessions skilled care. We're not just throwing random stuff at him in hopes that he just gets better. We're recognizing where the patient's what the patient's irritability level is. We're recognizing if there's swelling, if there's range of motion deficits. And we're also recognizing just any psychosocial factors that might be affecting this patient at the current moment. So all of these things in our wheelhouse for sure. And that's what makes our treatments skilled care. So this is really, really important, because if we look at the big picture of some of our master's athlete patients, it is so important for us to get our patients to this level of function for so many reasons. We could decrease their risk of sarcopenia. We could decrease their risk of osteoporosis. We could decrease their risk of getting comorbidities like heart disease and diabetes, because we have gotten them to a point where they can continue to do their activity and decrease injury and decrease risk of disease. And that is part of what makes our treatment sessions medically necessary. And this could mean the difference between them getting pushed around in the medical system because they're just not finding any real things going on, and keeping them in the gym where they can continue to have more of a trajectory of health rather than sickness. So if we're truly pushing the boundaries and trying to limit injury in our master's athletes, our plan of care should look like a strength and conditioning program towards the end, or whatever things are required for that sport, whether it's cutting, deceleration drills, jumping, anything like that, because that may be what they truly need and what they need to get back to. We, of course, have to recognize that not all of our older adults want to be master's athletes, and that's okay. But if they do, we are not stopping at patient is able to walk 500 feet without knee pain. It really has to mean getting them back to their activity so they don't just go back without any knowledge of how they can make this time around better. So, as a reminder, the APTA defines medical necessity as physical therapy is considered medically necessary as determined by a licensed physical therapist based on the results of a physical therapy evaluation. So that could mean your range of motion measurements, your rep max testing, looking at their movement patterns, all that stuff. Physical therapy evaluation, when provided for the purpose of preventing, minimizing, or eliminating impairments, activity limitations, or participation restrictions. Furthermore, therapy treatment is considered medically necessary if the type, amount, and duration of services outlined in the plan of care increase the likelihood of meeting one or more of these stated goals: to improve function, to minimize loss of function, or to decrease risk of injury and disease. Throughout our plan of care, this might look like putting out the fire using manual therapy and modifying movement, getting the patient's pain down, gradually getting them back to what that activity looks like for them. And in Bob's case, that was deep squatting, and Lastly, I really want to drive the point in that it is important for us to get our patients to this level of function, because it could be the reason that a patient continues to have a trajectory of health rather than sickness. If you guys have any thoughts on this, I would love to hear it. I think this topic is pretty cool because the master's athlete is kind of like a niche, setting or group that we can really affect positively. So I hope you enjoyed this podcast, and I look forward to being on the podcast again at the end of January in 2024. So I will see you all in the new year. I hope you all have a happy holiday, and we'll see you then. All right. Have a good evening. Bye.
Thank you for listening to the MMOA podcast. If you found this helpful, please share with someone that could benefit. And if you're looking for more practical content to help you better serve older adults, head over to www.mmoa.online, where you can learn more about our free resources, our community, continuing education courses, and our certification. Once again, that's www.mmoa.online. Thanks for listening.